This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome back to a recap episode of the Disrupt Healthcare podcast. My name is Lester Morales, and I am the host. And these recap episodes are just me recapping the conversation, trying to maybe dive into a subject a little bit more plainly. And sometimes it's just recapping maybe in a much shorter scenario. So you could listen to this, and then if you're at all intrigued, go listen to the full episode. But this episode, I am highlighting my conversation with who has now become a personal friend of mine, Rachel Strauss, the founder of PBM Princess. She highlighted in the beginning that I actually gave her that nickname. I had her on one of our webinars, and I introduced her as the PBM Princess. She liked it, and she took it. So for trademark purposes, if she gets rich and famous, I'm going to come after her because I gave her the name. Our conversations are always a third emotion, how crappy the situation is. A third enthusiastic. Man, there's a lot of good things happening. And a third, let's get dirty. Let's get technical. And Rachel is somebody that in the pharmacy world can get dirty. Rachel spent most of her career at a leading pharmacy benefit manager that from, I believe, its inception, never took rebates, didn't do the spread pricing game, and kind of operated like a lot of the movement in the industry is today. For those of you that don't know, a PBM, a pharmacy benefit manager, is the organization that administers and puts together your pharmacy benefit that's a part of your health plan. So your health plan does the medical side and the pharmacy benefit. Now, you probably think of all of that as one and the same because basically since the Affordable Care Act, the large pharmacy benefit managers and the large health insurance companies have united. United Healthcare owns Optum. CVS owns Aetna, and Cigna owns Express Scripts, and a lot of the Blues organizations, I believe it's 19, don't quote me on that number, own Prime Therapeutics. So of the four largest PBMs, they're all married to one of their insurance counterparts. And so Rachel and I, kind of always talk about why the game is the game. And so I want to break down a couple of the things, that we talked about and the reality of the game. And so I ask everybody to take your whatever you do for a living hat off and put your consumer hat on. You are a consumer of healthcare, and you are in the pharmacy acquisition conversation, meaning you're going to go get a damn prescription. And I want you to kind of think about this. Number one, you pay a copay as a consumer. If you're on the other side of that, have you ever stopped to think about what actually is the cost of that medication? And it's such an interesting thing because as consumers, we typically consume things that we know what we're paying for. And in healthcare, we kind of know what we have to pay, but we're not necessarily sure how we are and where that fits into what we're paying for. So a $10 generic could be a $4 drug. It could be a $2 drug. It could be a $700 drug. And the fact is that not a lot of people know it. And so one of the things we talked about are the games that are played with spread pricing. So if you are a advisor, and again, for the first 15 years of my career, I don't know that I really truly understand the games of this. I want you to stop and ask yourself, and Rachel and I talked about this, how and how much does your pharmacy benefit manager get paid? How and how much? It's a very simple question, but if you are fully insured and your rates include your medical and your pharmacy, and you have a $500 employee only rate, how much of that is going to the pharmacy benefit manager? You have no idea. You have no idea, and there is no promise from them to you that that $500, which theoretically includes their compensation, is their only form of compensation, which, newsflash, isn't even close to being the case. Pharmacy benefit managers make so much money in so many different ways, it's ridiculous. And so if you can't answer the question, how and how much, I am urging you to think about the pharmacy benefit manager that you're utilizing. If you advisors out there are placing all of your business with the big pharmacy benefit managers, I ask you to take a step back, because I'm telling you, I worked for a very large organization. We had our own pharmacy unit full of PharmDs and people that were doing this. But the reality of it is, when you've never seen the other side, number one, or just theoretically in your gut, let me ask you a question. Do you want to compensate somebody for selling you drugs? Meaning their compensation is tied to the amount that is ultimately paid for that medication? Or do you want to pay somebody for doing the job of getting that drug and doing the administration of it? So let's just take those two fundamental thoughts there and says, if I am attached as my compensation, my kids' private schools, my house, I don't have kids, but my private schools, the house, the boat, all the things is tied to how much I sell you the pill for, what's my vested interest to save you money? Think about that. If I make more money selling you more drugs and make more money the more I hide in the cost of the drug, why am I ever going to lower your cost? I want you to think about that. I want you to really think about that. And then I want you to ask yourself, have you ever actually seen the list price of the drugs that you're paying for? Have you seen how much you're actually paying for that amoxicillin, for that simple statin? And not how much the plan was billed, but actually, what did they buy it for? And so that spread pricing game, that black box that's full and rampant in the PBM pharmacy space is just terrible. And it's terrible on all sides because the consumer has no idea, the employer has no idea, and it's impacting the retail situations as well. Your local pharmacy, the guy or gal that's a staple in the community is getting raped and pillaged by the normal model. So the other scenario is what a small percentage of people are driving as a percentage of the overall cost. 1 to 3% of plan members, the belly buttons covered under the plan, 1 to 3% of them are driving 40, 50, 60% of cost. So when you start looking at just high return for very little effort, this is the space. This is the area you want to focus your time and attention in. A couple of things that Rachel and I talked about is, if you just worry about doing the right thing for the patient, it usually works out. And if you communicate to the patient about being a better consumer, like, we can help you do cool things, but you gotta do something different. It's crazy what percentage of people will actually do something different. And it's disturbing. Maybe even creates fury in me. The number of employers and advisors that simply say, our employees won't understand doing something different. Do you understand how far from reality we have gotten from the average person's day? Most of the people that will listen to my voice on this episode could afford a $1,500 exposure. The average person working at the employers of clients, the working as employees of our clients, can't afford that. And so when we, as the decision makers, the advisor, the CFO, the CEO, the HR, the carriers who drive up in our Bentleys and Beamers and Mercedes and nice cars, and who are in the HSA plan because we're going to save something for retirement. And the average person is trying to figure out whether they refill their insulin or pay their mortgage. And that's real. So if you're ever somebody who hasn't explored this because of change, or I've seen a couple of employers that not make a change because they're in the business and they're in a business that does business with one of these evil empire organizations, we gotta check ourselves. We have to remind ourselves what exactly we're getting up in the morning and doing. Because for me, when you look at 1 to 3% of the people, that's small of people, can help you save 50% on your health plan. And in that scenarios, you're going to hear from Rachel in this episode, between patient assistance programs, between international sourcing, between 340B partnerships. The reality of it is you can get the same exact medication and give it to your employees for free, because an employer saved 50, 60, 70% on that medication. But you can't do so under a model where the PBM makes money on selling you drugs. So listen to this episode. Rachel talks about being an advocate for employees. She talks about the gamesmanship that happens every single day. She talks about the horror stories that could occur when you're not doing it the right way. And it's just crazy when you think what you can actually do if you are willing to listen and do something different, but do something different for the benefit of the patient, your employee, the employee, their family, the human in the community that is figuring out how to make ends meet. That's what this episode is all about. So go listen to the full episode, learn the strategies, connect with Rachel. If there's a high cost drug on your plan, let us know so that we can tell you how we can help you source that medication. But again, you can't do so continuing to do the same thing. Tomorrow's problem and today's problem isn't solved using yesterday's strategies. Thanks for listening to the Disrupt Healthcare podcast. If you like this episode, if you like anything, if you just want to be a part of the damn change of this disgusting industry, give it a like, give it a follow, share the episode, help me out. I don't get sponsors for this. I am doing this because my family filed bankruptcy, and it's because of one drug that my dad was on, that my parents had to decide. Make a mortgage payment, keep dad alive. $62,000 on a credit card in debt. I don't want this to happen to anybody else. Help me out on this journey. Disrupt healthcare. It's not about the I, it's about the why.